Okay, I see that a few folks are trickling in. We're just going to give it another minute and then we'll get started. All right, we'll just give it one more minute, just in case anyone's having trouble clicking and getting into the session. All right, everybody, welcome. We're so excited that you're here for today's afternoon session. Today's 1 to 2 session is Understanding Aging and Hearing Loss. I'm Marguerite Corbini. I'm with the Center on Aging and Community Living, part of the planning team. So welcome. We're just going to go through a little bit of housekeeping before I turn it over to our guest speaker. I think most of you are aware of the closed captioning. I've seen your names and faces and little Hollywood squares in other meetings this week. So I'm not going to spend too much time on this. Subtitles are on and you can shut them off if you don't need them. There's cues on the bottom of your screen. If you have any difficulty, Bridget Drake is on. You can use the chat function to reach out to her, or you can send her an email, and I'll have her email up in just a moment. So we just have this disclaimer here that we are asking you to participate in certain exercises throughout the week and activities, and this is at your own risk. Reach out to your doctor if you have any concerns, or your medical provider. And here's Bridget's email, and she's on the screen there, bridget.drake@unh.edu. If you have any issues, please don't hesitate to reach out. She's here all week to help us work through any glitches. Thanks, Bridget. We want to thank our partners, our sponsors this year. We couldn't make this event possible without them, and we're really grateful for their support from year to year. American House, Bellamy and Watson Fields Assisted Living in Dover, the Alzheimer's Association, the New Hampshire Association of Senior Centers, AARP New Hampshire, and the Active Retirement Association. Thank you to our wonderful sponsors. Check out their vendor pages if you haven't already in Cadence. And a shout out to our outreach partners who've helped us spread the word about this event. And some have individuals gathering in a safely distanced manner at their locations. So thank you to Easter Seals, American House, the Conway Public Library, Tamworth Cook Memorial Library, and the Portsmouth Senior Center. And just a reminder that today's focus is on the dimensions of wellness. Well, the whole week focuses on the different dimensions of wellness, and today's focus is the social dimension. So with that, I want to turn it over to Mary Jane Sullivan for today's presentation. Mary Jane is an associate professor at the University of New Hampshire, and I just learned that she's been there for 20 years now. She is an audiologist, and so she's got a wealth of experience, and she's here to share her wealth of information with us. Mary Jane, I'm going to turn it over to you.
Okay, thank you, Marguerite. Can everybody see my screen? Somehow.
Not yet. Okay. It's probably because I was sharing. So now try again and you should be able to share.
And let's see. Let's do here. Okay, how about now?
Perfect.
Okay.
Yep. There it is.
Great. Welcome, everybody. Thanks for joining us today. I know it's beautiful outside, so I appreciate that you're in front of your computers right now. So as Marguerite mentioned, I am an associate professor. I'm an audiologist. I've been working clinically for many years and have, I think, an appreciation for sort of what happens to your hearing as you get older. And if it's any consolation, you actually start to lose hearing in your 20s. When infants are born, you can hear in quite a large frequency range from 20 to 20,000 hertz. And at about early 20s, you start to have a decrease there. So this progression has been occurring for many years, if anybody currently is experiencing any hearing loss. So let me go to, for some reason, it's not letting me forward here. So about a third of the adults between 65 and 70 are expected to have some degree of hearing loss. And that increases once you get to be 75 and older. And then we're looking at least 50% of individuals will have some degree of hearing loss. And I want to, happy to answer any questions as we go along. Feel free to interrupt me. And if it's more convenient to type your questions in the chat, we have somebody monitoring that as well. So feel free to jump in either direction. So I just want to give a little background in terms of how we, as audiologists, define hearing loss. And there's a couple parameters that we use. We use what we call type of hearing loss. And for any individual, regardless of age, there's only 3 types of hearing loss. There are sensory neural hearing losses, which is one type, conductive is the second, and then mixed hearing loss. And the type of hearing loss indicates what part of your ear is damaged. So when you do an audiological assessment, it's really important that someone can share what type of hearing loss, because depending on the type, it may be something that's medically treatable. It might be something that is needing attention more quickly than some other type. Majority of people who have an aging related hearing loss have a sensory neural hearing loss. And that is indicating the part of the ear that's actually damaged. The other thing that we look at is the degree of hearing loss. And some of the terminology for that is mild, moderate, moderately severe, severe to profound. And the degree, in part, will predict to, or help us predict what kind of communication issues will exist. And you can have different degrees of hearing loss in both ears, or you can have the same levels of hearing loss. It really depends on the cause. And then the other thing that we look at is what we call configuration. And that's indicating, do you hear similarly across pitches so that you hear low frequencies at the same loudness level as that you hear high frequencies? So again, the configuration, which is when we get later, and I'll show you how we measure that, gives us some predictive value in terms of communication function and potentially what kind of interventions might be helpful. The other thing that's important for us to measure is not only how loud things have to be for you able to hear it, but what the clarity is for that signal. So I'm not sure if anybody who's joined us today has actually had a hearing assessment. If you have, what you might recall is they should have given you a list of words to repeat. And we're really looking at when we overcome or provide enough volume that your hearing loss is not impacting as much, how clearly is that speech signal getting to your brain? So in order to know all of these parameters, it's really important that you have diagnostic testing done. And generally the best place to have that done is by an audiologist, because they're going to have the equipment to do all of the above. There are lots of opportunities out there to have hearing screenings done, and a screening is very helpful to determine if you need further testing, but a screening doesn't give you all the information that is needed to really help you determine, or someone else to help you sort of decide what the next steps are being. So what I really think is important to emphasize is I think the perception is the only reason that you'd go to see an audiologist if you have an age-related hearing loss is to get hearing aids. And that might be one of the outcomes, but it certainly shouldn't be the only reason that you go to have a hearing test done. It's really helpful to have a baseline test done. Based on that information, we could give you communication strategies. There might be, and in fact, there might be some medical interventions that are appropriate as well. So I would highly encourage anybody who's having any questions of hearing loss to consider pursuing an audiological evaluation. And so when we think about hearing loss related to aging, the term that we use is called presbycusis. And it is the most commonly occurring cause of acquired hearing loss. So when we talk about people's hearing progressing with time, it is described as a presbycusic type hearing loss, but we aren't able really to predict when that's going to occur for somebody or how quickly that progression is going to occur. What we do know from the research is there are definite predispositions. So as with many things, genetics plays a big role in at what age you're likely to experience a presbycusic type hearing loss. And looking at parents and at what age they might have had hearing loss, sometimes you might have parents, or you might recall that potentially they didn't have their hearing tested, but maybe behaviorally you were noticing that their hearing decreased. So testing was not occurring as frequently as it is now. So you may not have that information, but certainly a genetic predisposition exists. And the other thing that's really important to know is what someone's listening environment has been over the years. So anybody who's been exposed to consistent noise sources, so someone who might have been in the military and had noise exposure as someone serving in that capacity, or someone who might have had a noisy occupation, they are more likely to start to show presbycusic type changes more quickly than someone who might have had a quieter lifestyle. So typically what we expect when presbycusis is occurring is most frequently what people are noticing is the clarity of speech will be impacted. So it might appear that people are mumbling. And in fact, there are certainly lots of mumblers out there. However, if that's something that's becoming more frequently occurring, it's likely that maybe your hearing's changing a little bit, because that's one of the characteristics you'll notice. The other characteristic is that the communication challenges will be much more noticeable when there's noise in the background and or when the speaker is not providing visual cues. So potentially their back is towards you, or they might be trying to speak from another room. That's going to be much more problematic in terms of understanding what someone's saying. And thirdly, which I think is maybe most important, particularly if you happen to have a spouse, a friend, someone else in your life who might be experiencing the hearing loss is that the person who has early onset presbycusis is the least likely to be aware that it's occurring. It usually is much more obvious to their social partners, so that the other person is doing the repeating and or the other person is noticing that they're misunderstanding what was said. So it typically is more obvious to others at its very beginning stages. Any questions so far? It is hard to.
I don't see any questions in the chat, so
Okay.
not
Great.
yet.
All right. So this is a very busy slide, so don't let it get overwhelming, but a diagram of your ear, and to the left here is what we call an audiogram. And what's important about an audiogram is it gives us an ability to establish the softest levels that you're able to hear all of the different pitches. So to the left here is from very soft to very loud sounds. Anything between 0 and 25 in terms of a loudness is considered to be within normal limits for adults. So for this particular graph, and the X's are your left ear, the circles are your right ear. That's the case for every audiogram. So you could compare them across centers, or if you were tested in another part of the country, you would have a similar audiogram that we could compare it to. So all of those X's and O's should be above or at the 25 decibels line. So it would be up here. Unlike most graphs, audiograms are actually a little backwards because the closer to the top that you are indicates the better hearing that you have. And generally we're used to reading graphs in a different direction. So that's sometimes confusing for people. But in this case, what's indicated is that someone has fairly normal hearing in the lower pitch sounds. So down at the bottom here, we have 250 hertz, which is a very low pitch sound, up to 8,000 hertz. And the reason we test these particular frequencies and loudness levels is that's where all the speech information falls. So you are able, particularly at different parts of your life, able to hear at lower pitch sounds than 125 and higher pitch sounds. But the information we're most interested in is in this range because that's where speech information falls. So for this individual, they have essentially normal hearing through the low and mid range, and then it drops down to moderately severe hearing loss in the high frequencies. So this person, in terms of communication, would always hear that someone was talking, but what they wouldn't be aware of is the speech sounds that fall in this area. So that's the perception of somebody mumbling. If someone with this degree of hearing loss was looking at the person, was communicating in a really quiet situation, knew the context of the conversation, they could probably do a pretty good job filling in the blanks. If I change that situation so that someone's having a conversation maybe from the kitchen and the person with this hearing loss is in the living room watching television, they're going to misunderstand a lot of what was said because they're going to know someone's talking to them, but the distance and the fact that they can't give, they don't have any context to go to, nor do they have any visual cues, they're going to misunderstand most of those. So an audiogram does predict a lot for us, but it will not predict how you do in every communication situation, because those are going to vary depending on the speaker that you're trying to listen to and also the environment you're trying to listen within. So there's going to be a lot of variations. When we talked about the types of hearing loss with the picture of your ear, a sensory neural hearing loss, which is what happens with presbycusis, is impacting the cochlea, which is this part of your ear. And within this, if we could open it up, there's, which we can right here, Not really, just a picture. There's a series of hair cells, which are indicated by sort of this dark shading. And as you get to the higher pitched sounds, those hair cells are going to get damaged. And the hair cells at the end of the cochlea, so if we were to uncoil it, you can see the hair cells that are responsible for the highest frequencies. Whoops, didn't mean to do that. Let's go back here.
Mary Jane,
yes.
You mean that the hairs get damaged over time, or that the high pitch frequency damages the hairs?
So the hair cells are responding to the pitches that your ear is picking up. And because over time those hair cells don't remain healthy, there might be many things that can damage them, noise, circulatory kinds of issues. If there's a hair cell range here, it's not going to pick up that particular frequency that it's supposed to be hearing. Did that answer your question?
Yes, thank you.
Okay. So anatomically, we know why the hearing in the high frequencies gets impacted first. That's not the case for all different kinds of hearing losses, but it's certainly the case for presbycusis, that you're going to be more apt to have a decrease in the high frequencies first. And then eventually that damage may move down so that you're starting to show a hearing loss in the mid and low frequencies. But the initial pattern of presbycusis would look like this, with the poorest hearing in the highs and the best hearing in the low frequencies. So, you know, the kind of use it or lose it mentality applies to your ears as well as anything else. And many times when I was working clinically, people would come in and say, you know, do I need to do something about my hearing loss? Is that a problem? And it does make a difference if you don't stimulate your brain with the information. So the longer someone has an untreated hearing loss, the less likely they are to do well with something like amplification or hearing aids, because your brain gets less accustomed to using that information. So intervention is a good thing. And the other thing to remember, even though we pay a lot of attention to the ear itself, we don't hear with our ears, we hear with our brain. And the longer that stimulation is either atypical or is not getting stimulated, it's harder for someone to then get accustomed to then hearing the noise if we are producing those through a hearing aid, for instance. So one of the probably most important pieces of research related to presbycusic and untreated hearing loss was done by Franklin. He's has numerous degrees. He's very impressive and a wonderful speaker. So I've been able to hear him at a lot of conferences. But his group did a pretty large study of 2,000 adults. And their question that they could have wanted to answer is, was hearing loss related to cognitive decline? And for many years, the assumption was that as people got older, their hearing decreased. And for some percentage of those individuals, as they got older, there was a higher incidence of cognitive decline. But the assumption was that those two processes were happening separately. And what his research showed is that untreated hearing loss, individuals who had at least a mild to moderate hearing loss that was not treated in any way, had 2 times the increase in dementia. So instead of those being 2 processes that were existing separately, they were interacting in a way that if the hearing loss was treated, then the rate of dementia went down significantly. The other kind of information that came out of the study is, gait issues, stability, fall risks also increase with age. And they found that some of the auditory cues that were available to individuals did actually reduce that as well. So once they indicated that there was a connection here, then they did further studies to really evaluate if individuals were fit with amplification, did that cognitive decline risk go down? And the answer was absolutely yes. So not only do we know it occurs, we also know that there's some pretty significant benefits even beyond communication to think about treating that particular hearing loss. Any questions so far?
I don't see any questions yet.
Yay.
I think this is such great information. My guess is people are taking it in right now.
That's okay. So, in summary for their finding is that, because of their findings, really what came out of it is that hearing really started to get a lot more attention, or hearing loss, as a global health concern. So it's part of the Healthy People initiatives, which, hadn't really gotten recognized in the same way before. With our aging population, we're seeing the prevalence of hearing loss doubling with every decade. And most importantly, that there are some pretty significant consequences of age-related hearing loss in regards to the dementia piece, the cognitive load, how effortful it is to be listening in the presence of a hearing loss. We also know that as you start to experience presbycusis, that it's really going to impact how effectively your brain is encoding auditory information. And if in fact it is untreated, that it's going to be harder for you to encode that information successfully if your hearing loss continues to decline. And the other thing to think about, unlike most other sensory systems, hearing is really our only system that is continuously on. So that regardless whether we're thinking about hearing or not, we are always hearing, even in sleep states where the auditory system is active. Obviously, it's not necessarily being attended to. And people are very reliant on some auditory cues beyond just helping with communication, essentially. So even though that progression is expected and not atypical, that maybe the consequences of not paying attention to that decline are a little greater than we had ever thought.
Mary
So
Jane, I had a question on the other slide where it says effortful listening. I'm wondering if that applies to both parties, both the individual with the hearing loss as well as the individuals communicating with that individual.
absolutely. So, the communication breakdown can, obviously with the person that has the hearing loss, it's on the reception end. But for those people that they're communicating with, it's very effortful, sometimes stressful for the person who is not experiencing the hearing loss to continually try to supplement those things. And what tends to happen, if you think about kind of social engagement, is there's usually either the choice of not engaging in those difficult listening situations. Oftentimes groups, people don't enjoy going to, for instance, if they happen to be in a bridge club or some kind of group activity, people would report, oh, it's so much more difficult to go now because I'm missing what people are saying as we're engaging in that activity. So the social impact of untreated hearing loss has been well established over the years and is certainly an issue. So it can certainly impact the listener as well as the person that they're communicating with. So I think, actually, I think there was another slide that I actually want to go to first. As a result of Dr. Lin's research and his group, there was a big initiative to look at the access of hearing aids to individuals who are having age-related decline. Hearing aids are not inexpensive. They're certainly an investment for people. Unfortunately, Medicare does not cover the cost. So their concern was, we have this research that indicates that there is a tie-in to age-related hearing loss and dementia, but we're basically not allowing hearing aids to be financially accessible to many people if they didn't have those resources. So at that point, one of the questions became, would there be some availability? Can we make hearing aids more accessible in terms of not having them be the expense that they are? So as a result of that, there was a law established in 2017 called the Fda Reauthorization Act. And basically what that allowed to be happening and was that over-the-counter hearing aid sales would be occurring. This was supposed to get final approval in spring of this year. And as you might imagine, due to COVID, it was one of the 1,000 and things that got delayed because of the COVID issues. So that has not officially gone into law, but it is in the works, and I'm expecting that it will be happening soon. And essentially what this means is that there are hearing aid manufacturers that are going to and have manufactured particular over-the-counter hearing aids so that they will be for sale at your Walgreens, Rite Aid, etc. As you might imagine, there's been lots of discussions, some more heated than others within the profession of audiology in terms of whether this is a good thing or not such a good thing. So I will give you my insight on this is that, given what we know about that, less than half of the people who could benefit from hearing aids are wearing hearing aids. My hope is that this might improve access for individuals. And, the over-the-counter hearing aid sales are really only meant for people who have kind of your simplest and most predicted decline in hearing because of aging. It is not meant for the pediatric population. That was one of our concerns. I spent a lot of my career working in pediatrics, and we certainly, the needs and demands for infants and very young children and what we need to do for those people when we're fitting hearing aids is quite different than someone who has a presbycusic type hearing loss. So that was one of the concerns, but the reality is my hope is that we are now just allowing more access. That does not mean that it's not important to see an audiologist to get a full audiological evaluation, but based on that evaluation, they may indicate that an over-counter hearing aid would work adequately for you. So that potentially would, give you opportunities. Hearing aids range in price pretty significantly based on the technology that you're going to use, but most of the over-the-counter hearing aids that I think are in the plan would be in the $100 to $150 range, which is significantly less than other hearing aids. And again, if you have more complex hearing aid needs, it's unlikely that an over-the-counter hearing aid is going to do what you need it to do. But that's where the audiologist would be helpful in kind of determining whether that would be an appropriate option for you or not. Any questions about that?
I don't see any questions in the
All right.
chat.
So hearing aids are absolutely helpful for individuals with presbycusis. There was a time, and there may still be individuals in some of the medical communities or allied health who might recall that presbycusic type hearing losses, there was many years ago, we did not have the technology that actually allowed us to be very successful for fitting sensorineural hearing losses. That is no longer the case. It has not been the case for many years, but if someone wasn't kind of keeping up with the changes, that might still be something that people are believing out there. I can tell you with certainty that there's really, majority of any hearing loss, regardless of type or degree, there is a hearing aid technology that's likely to provide significant benefit. And then if for traditional hearing aids, your hearing loss is too great for it to be beneficial enough, that's when we would consider a cochlear implant, which is a different technology altogether. And probably in the last 4 to 5 years, there's been what we call a hybrid cochlear implant. For those of you not familiar with a cochlear implant, they do not function like a typical hearing aid. Basically, you do an insertion of an electrode array in that cochlea, and we're bypassing the normal function of the ear, and we're turning it into an electrical stimulation. Cochlear implants have come quite a ways in terms of development and gains that individuals can get. But most recently on the market for cochlear implants is what we call a hybrid. And what that's allowing individuals to do is if they have a very severe high frequency hearing loss, which can happen with presbycusis, but much better hearing in the lows, we now have the ability for the cochlear implant to preserve where the hearing is good, which used to be the case. Once we put in the electrode array, we basically would obliterate any hearing that was there. But we now have the ability to preserve where the hearing is good and then use the implant technology to provide input and in the area where you have a severe hearing loss. So that has opened up a whole nother category of technology that didn't used to be available to individuals with presbycusis. And then there's a variety of communication strategies, some very easy to initiate, in terms of using visual cues, reducing background noise, guidance in regards to how best to communicate with somebody with a hearing loss to make sure that the speaker is looking directly at you. And those are really quite helpful and certainly not usually something we'd recommend in addition to technology. And then there's a whole category of assistive devices. So that might be a telephone amplifier. It might be an FM system that someone uses if they're still employed in a work setting. And an FM, what that does is keep the speaker's voice. The speaker uses a microphone, which is part of the transmitter, and then the sound is transmitted to the individual with the hearing loss. And regardless of where that speaker is in the room, the volume of their speech is going to stay the same. So there's a variety of assistive devices that are also extremely helpful. And sometimes there's individuals who use a combination of all of the above and to improve their hearing. We already went there, we're gonna go over. But most importantly, is hearing loss is not a one-size-fits-all kind of diagnosis. And in order for any intervention, whether it's amplification, communication strategies, some kind of assistive device, it really does need to be individualized. And in order to individualize that, it's important that someone has the background and that you see a professional that has all the information necessary to make sure whatever the recommendations are for your hearing loss, that it's going to make it better and improve communication, which ultimately is everybody's goal when they start experiencing hearing loss. And again, back to the questions that we get frequently is, well, I don't think it's bad enough to do anything. The reality is any degree of hearing loss can be intervened successfully. And again, the research that we have from Dr. Lynn's group, there certainly is benefits beyond communication in terms of intervening and trying to address any hearing issues that might be occurring. So again, effective communication is extremely reliant on having usable and adequate hearing. And the fact that we know any degree of hearing loss might be supporting and contributing to cognitive decline. It's well established that it's very much related to social emotional health in terms of being able to hear grandchildren, to continue to interact in large groups, and even in smaller communication situations with a spouse, with a son or a daughter, whatever the circumstances might be, if hearing loss is interfering with that, then obviously then you're going to have some more isolation issues happening. There's also tie into people's physical well-being because, there might be more, there can certainly be some tie into other conditions, individuals who have diabetes, who have cardiovascular, untreated blood pressure, they're going to have more likelihood to have presbycusic changes happening more quickly. So potentially they might be paying more attention to those types of conditions as well. I just wanted to mention a couple resources. I don't know if we have anybody who might be a veteran who's signed in today, but through the VA, they do provide amplification at no cost to veterans if you qualify, and the financial qualifications are quite generous, so most people would qualify for that. They also provide audiological services. In our state, there's audiology in the Manchester VA program. I think people are sometimes reluctant to go to VA for these kind of services. I can tell you that the veterans, the VA in New Hampshire, as well as many facilities across the country, have access to really the best technology that's out there. And the fact that it's at no cost to somebody is quite significant. The other potentially free service is through CapTel services, and I've included the website there. They provide a phone that has the written word, along with, if you're struggling at all hearing over the phone, they will provide you with a CapTel phone that gives you the word's escaping me, but it as you're speaking or the person who's speaking to you, you see the typewritten word. So it's like closed captioning that's happening. And those, all you need to do is have documentation of a hearing loss. It has no tie into financial status, and they will provide that free of charge. In the state of New Hampshire, if you have private insurance, there is a requirement that they have coverage for hearing aids. So if your insurance, if you happen to have something beyond Medicare, you should definitely check and see if that might be a benefit for you. And if it isn't, it's always good to let them know that that should be something. Again, What that insurance coverage looks like is going to be quite different depending on the carrier, because the law is in New Hampshire that they have to have some benefit, but they don't necessarily indicate what that benefit is. So those are certainly important resources if you're thinking about pursuing any technology. And I just want to touch a little bit, again, communication strategies are really easy to start initiating, but they take effort. Most of us don't really think about hearing. If in fact you have normal hearing and we're communicating quickly and not necessarily doing it in a way that's helpful for individuals with hearing loss, the immediate strategy usually is to increase the volume of somebody's voice. And for most people with presbycusis, louder does not make it any clearer. So if you have a tendency to, if someone misunderstands, it's most helpful to rephrase what you said rather than say it louder. If you say it louder and you say exactly what you just said, but increasing the volume, what they're going to get is a louder, unclear message, which doesn't really help at all, because the issue for that person is not the volume. For the most part, the issue is that they weren't getting all the different speech sounds. And by rephrasing it, you're likely to make it easier for them potentially to hear different speech sounds that they might be in a range that they hear better. Visual supports, so looking right at them. Everybody uses visual supports. People think about it in terms of lip reading or speech reading. Everybody is reliant, even people with normal hearing. If you find yourself in a really noisy situation, you're always going to hear better. It's kind of the audiology joke of, I hear better with my glasses on. And the reality is you do, because you're going to be relying on those visual cues. And most importantly, that we hear with our brain and not our ears. So if you don't stimulate that brain, it's more difficult later down the road for your brain to make sense of the stimulation that's coming in. It's important to keep those auditory systems in check and making sure that they're taking in the information as adequately as possible. There are different things that happen in addition to losing different pitches. There's a condition called phonemic regression, which means that the clarity of speech is getting reduced. And that's something that happens for some people with presbycusis. So even within this diagnosis, we're going to have a lot of differences in terms of how much or how little someone is going to struggle, which is why, I think the tendency is to just say, oh, well, that's just half of being 70 or 80 or 90 or whatever the case might be, is that I'm not going to hear well. And the reality is there's a lot of differences in between, 2 70-year-olds who might be starting to have hearing loss are going to present quite differently. So you don't want to just assume that it's easily predicted and that there's nothing you can do about it, because in fact, there's lots we can do about it and things that would have some pretty long-term benefits as well. The other, comment that I think it's just important to realize is just because you happen to be at an advanced age does not mean that your hearing loss is occurring because of the aging process. Individuals can get conductive types hearing loss because potentially maybe they have wax infection. They could get ear infections. They can get fluid behind their eardrum. They can get the different types of hearing loss. So unless you're actually having it evaluated, you don't know for certain what kind of hearing loss you have. And that's the other sort of hopefully motivating factor to think about having at least a baseline test done by an audiologist so that you can rule out that there might be some medical intervention, because in fact, there's certainly many occasions that there might be something that's treatable, and you're just assuming that it's related to the aging process, and that might not be accurate. So again, stay tuned. The over-the-counter hearing aids are coming. And again, they potentially will be beneficial for some percentage of individuals. But I want to really caution people to, that is not a reason not to get a full diagnostic appointment. You're going to be much more likely to be successful with something like an over-the-counter hearing aid if you have enough testing done. You'll see more and more, and I think it's happening, attention to the impact of hearing loss, particularly in the social emotional realms. It's getting a lot more press, and I think rightfully so. Again, I think, when you have normal hearing, you kind of take it for granted. When it starts to go down, it's easy to ignore because unless you choose to attend to it, no one's really seeing it. But I can tell you it's usually obvious to other people, whether you know it or not. Technologically, the advances have been really, really significant in the last 20, 30, 25 years. There's the clarity, the types of hearing aids that are out there are significantly different. So, if you happen to know somebody who maybe had hearing aids 30 years ago and they were sitting in their drawer because they hated them, I would agree that that was probably where they belonged, but we're really not there now. We're really at the point where there's technology that's significantly better. There's lots of lab work going on in terms of hair cell regeneration. Not sure it's going to happen in my lifetime. I'm pretty sure that's not the case, but at some point it will potentially be an intervention that we can actually have that inner ear repairing itself. But the fact that we have the technology that we have is really super helpful for most people at this point. And that's it for me. So thanks for everybody's attention. I don't know if people have questions, comments, anything.
Thank you so much, Mary Jane. That was amazing. My jaw, you couldn't see my face, but my jaw definitely hit the floor a few times.
Well, good. Glad to hear it. That's, again, I think it just, everybody's just so quick to just say, oh, it's just one of these things that are going to happen and we don't need to do anything about it. And I'm hopeful that maybe we can get past that kind of approach.
Mm-hmm. Yeah, definitely. So I picked up some great information. I'll definitely share with family members of mine. But we do have time for questions. So don't be shy. You can unmute, write in the chat if you're more comfortable with that. We'd love to hear your thoughts, comments, or personal experiences or any questions.
So has anybody that's willing to share who's signed on today had any experience with audiology or amplification? Maybe for yourself, a family member?
Hello? I can't see anyone, so.
Hi, Gail.
Hi, how are you, Marguerite?
Good.
Good. I just was wondering, my husband has a severe hearing loss and has worn hearing aids for, bilateral hearing aids for quite a few years. But my son bought him earphones, to be able to, what do you call it? Like on Bluetooth to listen to the TV.
Mm-hmm.
And when he puts them on, no matter how loud, one of us will try it on and it'll be on loud, 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 loud. Put him on his ears, he absolutely cannot hear it.
Again, very faintly.
Very faintly, but not good enough to be able to listen to a program. I asked the audiologist at one time and she didn't know.
So are you using the headset for the television on its own or in conjunction with your hearing aids?
Go ahead. He's right here. Go ahead, answer.
Oh, sure.
Oh, you didn't hear. He said, no, he's tried it both ways. With the hearing aids, he doesn't like it because it makes the hearing aids
The whistle,
the
the
whistle.
whistle.
Yeah.
Right.
And so he tried it without the hearing aids.
So I'm guessing that it's not giving you enough amplification without the
Yeah.
hearing aids.
Yeah.
Most individuals, if they have a severe hearing loss, are actually going to use a program so that they can actually get the TV signal going directly into their hearing aid. Depending on what you're wearing for technology, there's different ways to do that. Have you spoken to the audiologist about that?
He does have that. He does have that right
Yeah,
now.
what I use now, the hearing aids I get, and I get them through the VA because my hearing loss was a result of my military service.
Mhm.
And these last ones I gave, there's a device that you kind of plug into the back of the TV, and I
Right.
have a button on my hearing aid, and the sound comes directly from the TV right to my hearing aid, and it's fantastic.
Yes.
It's really fantastic.
Yeah.
And
Yes.
what really makes that good too is that if Gail goes to bed at night or something, you can actually turn the the sound off on the TV, but it still comes through my hearing aids.
That's
So
right.
it wouldn't disturb her at all. It's really wonderful.
The only
Yeah,
bad thing is when I want to talk to him, he can't hear me because he hears the TV.
Yeah. She's overpowered by the TV.
Yeah, but the ability to get that direct audio input from the television is really huge, and I'm glad it's successful for you. That was what I would have suggested that you talk to them about, but it sounds like that's already happened, which is great.
Yeah. Yeah. The other thing that I mean, I've had so many hearing aids over the years, since around, I don't know, late 80s, I guess, starting with one in one ear, and then a couple. I've had the behind the ear kind. I've had the in the ear, which is the ones I prefer the most. What's distracting to me is that it's almost like whichever sound I hear first becomes a primary sound. And like if we're in the car and the car is the radio is on or something like that, Gil becomes the background noise.
Right.
And it's like whichever sound you hear first, it's loud, it's fairly loud. It's overpowers whoever's with you. That's I don't know if it's these particular hearing aids or
Well, and
what.
sometimes it is the settings. You know, even though we've come in an enormous way in regards to technology, it's not a new ear. So
Right.
and the fact is that your brain is going to respond to what's most obvious immediately, because that's just typically what we get used to listening that way. But you can certainly program hearing aids so that it's going to recognize the speech signal, but as you might imagine, right, the radio is also a speech signal. So when they've programmed your hearing aids to bring that speech signal into you, that's where the competition is going to be occurring from, do we pay attention to the speech signal from your wife or to the radio? And that's where that hearing aid doesn't have a brain to know, okay, which one do I want to attend to?
Yeah.
So it does get a little tricky in terms of then it becomes kind of putting that in the background and or doing some modifications so that you're actually lessening the competition from that radio.
Yeah.
You got time for one more question?
Sure.
Yeah. The other problem that I have specifically is I have tinnitus, and it's constant. And sometimes I have up to 3 different sounds coming through my head at once. It gets really bad, but boy, does hearing aids really help that, because once you get some other sounds going into your head, you're not distracted by the tinnitus as much as you normally would. So I just and you know, we belong to the Active Retirement Association, and it's amazing to me that there are still so many people who are our age, you know, we're in our 70s, who experience a hearing loss, but they will not get hearing aids. You know, I kind of mad, because I can remember the first pair of really good ones I got, and the increase in volume and the sound that you hear, is so incredible compared to without hearing aids. And I don't know if it's so much a vanity thing with some people, or the cost could be,
Right. Well, and I think it's a lot of things. It can certainly, vanity will play in. Cost is a huge barrier. Hopefully that's where over the counter, but you would be, the perfect example that an over the counter hearing aid would not be beneficial for you.
Right.
Because you have more of a severe hearing loss. And fortunately you have the VA who can provide those for you. But you're right. I mean, it's really unfortunate that there aren't more people that are using the help that's out there. But I do want to comment, and I'm glad you brought it up, in terms of the tinnitus, which basically is just a noise in your ear that occurs when you have a hearing loss. It can also occur if you don't have a hearing loss, but it's most likely to be related to the noise exposure. I'm assuming that you've had over the time. And one benefit from amplification is if someone is experiencing tinnitus, when you're fit with amplification, oftentimes the tinnitus symptoms go away. It doesn't mean the tinnitus is gone, but they don't get processed the same way. So it's not going to bother you like it would without hearing aids in.
Right. Thank you.
Jane, sorry, I just want to acknowledge it's 2 o'clock, and if others have meetings or they want to attend the next session, please go ahead, and I put the link in the chat. And thank you so much for coming. This was a really wonderful presentation. I will stay on for a few more minutes if you want to keep the conversation going, if you have time, Mary Jane.
Yeah, I do. If anybody has questions, I'm happy to answer more.
Okay, great. So we'll just leave it open for a few more minutes. So Bob, Gail, could please go ahead and ask more questions.
I hate to say, but I forgot about the program and turned it on at 2:30. So excuse me if you've already mentioned this. You mentioned a Dr. Lynn's group.
Right.
Yeah, is because when Bob goes to the VA, he's getting them for free and all that, and it's all wonderful. And we got this other thing for the TV, but it doesn't seem like we've been able to really talk about things, a lot of things like you talked about rephrasing rather than saying something louder, and, those kinds of things, and what other kinds of equipment that we could get that would specifically fit, our needs. And I don't feel like, maybe I'm wrong, but that we've gotten that bit from there. So what kind of a person, or who should we go to if we wanted to get answers to those kinds of things?
So in terms of strategies, is that what you're?
Yes.
So sometimes that falls more in what we reference to be called oral rehabilitation. So that's something that they provide groups for. Sometimes they do it as part of hearing aid orientation. For instance, in our speech language and hearing clinic at UNH, we do have individuals that come in for therapy that focus specifically on improving communication. So it tends to fall more in a therapy arrangement, and it might be kind of short term, 2 or 3 meetings to go over different strategies, because it's important to have all the pieces to really kind of guide someone in terms of the best ways to maximize either technology or their residual hearing that they have, or whatever the case might be. So there's, I would say, in terms of, pursuing a therapy, oftentimes might be provided actually by a speech language pathologist. The speech pathologist, in at least for our clinic, would work collectively with us in terms of what kind of strategies would be helpful for people.
So is that only open to UNH people?
Nope.
Students and faculty?
Nope, it is open to general public.
Oh, speech and language. What did you call it?
It's this UNH. It's the Speech Language and Hearing Center.
Speech language and hearing. Okay, thank you.
You're welcome.
We can email that information over to you if you want.
That would be great. Okay, that would be great. Thank you.
And if you missed the beginning of the presentation, we're recording this and it will be on YouTube, so you could go back and review it.
Right, because Bob
Yeah,
didn't hear that.
that's-
Yeah,
Yeah, we will. Thank you.
yeah, thank you.
No,
I just wanted to be able to ask a question when you could actually ask a question, because you can't ask a video question.
No?
That's
No.
right. However, my contact is there and I'm happy to be a
Oh, great.
resource. So if
Thank you.
after watching have some other questions you wished you could have gotten answered, feel free to email me.
Oh, thank you. Wow, and all this was for free.
yeah, isn't that great?
Yes, it is. I can see it was an excellent program. I'm just sorry I didn't get to it sooner, and Bob didn't either. So we will
Well, you
definitely
did.
watch it.
You got to ask your questions, and
Yes,
you always go back and watch it. And then Mary Jean,
right.
we're connected
And
with
feel
her.
free, like I said, I'm happy to answer any questions after you take a look at the beginning.
Oh, thank you, Mary
Okay,
Jane.
thanks.
Okay. Well, we don't want to hold you up any longer. I don't know if there's anyone else there left.
There's a few other people on, and before we wrap this up, does anyone else want to unmute and ask a question? Okay. They're feeling shy. You have Mary Jane's information. So you can always email her if you have follow-up questions, or you can email anybody from the Center on Aging and Community Living, and we will connect you.
Great.
So thanks everybody for joining.
Thank you.
Thank you very much.
That
Great.
was just really wonderful.
Have a nice afternoon, everybody.
Thank
Thanks
you.
for
You
joining
too.
us. All right. Take care. Bye-bye.